So what I will talk today is about these procedures, this intervention called ALPPS, and I will try to do a summary and give you an update about the topic. I think first it's important to know what we talk about. So we are talking about patients with massive liver disease, many tumors in the livers, which are usually considered as unresectable in many situations. So you know upfront that you deal with a complex population of patients with not many options. That I will try to go during this talk, the half an hour that we will have together, and in the beginning to speak about the ALPPS and what it is, whether we have any comparative study. I would speak a bit about the registry, and then a novel model that we have developed to understand that better and the future. So the development of ALPPS, I think we have to go back what we have done so far. And what we have done, two-stage procedure is not new. We are doing two-stage procedure, and this is the classical one that has been done now for many years. When you have a patient with either a very large tumor or multiple tumors, you will do either portal vein embolization or surgery, portal vein ligation, and you clean the left part of the liver. Usually you will wait 1 to 2 months, hoping that the remnant liver will grow, and that's what you expect. There is different cutoff. If you have more than 30% or 35% in the liver that you want to keep, then you can proceed with the second stage procedures. So you go in a period of about 2 months or 6 weeks from a liver full of tumors to a disease-free liver at the end. This is an example of such patient that we have treated. That's what you have here 6 weeks later after portal vein ligation and wedge resection on segment 2 and 3. Intraoperatively, it looks like that. You have a number of these small tumors, a metastatic colorectal tumor. You do some wedge resection. Here, you ligate or cut the portal vein on the right side, and that's what you can achieve on the second stage, a liver which is in good health and in a good size. Now, what's the problem with this operation and why we had to develop something new is that if you stay between stage 1, portal vein, and stage 2, only 60 to 80% of the patient that you go for stage 1 will eventually reach stage 2, which means that 20 to 40% will fail, either because the liver does not regenerate enough or the tumor will grow during that period. So you offer surgery to this patient, but at the end, they will never benefit from a curative resection. Now, in 2012 came this article published by a German group, was multicentric here, about 25 cases, and I will describe this operation a bit better. And we had the honor, I had the honor with Dr. de Santibáñez to write an editorial. We had in both centers already performed a few of those procedures, and we propose the acronym ALPPS for Associating Liver Partition and Portal Vein Ligation for Stage Hepatectomy, and this is now quite worldwide as the ALPPS procedure. So what is it? In summary, it's the same that I described before, except that here you do the portal vein ligation, but you will do a split of the liver between the part you want to keep, the partition, and the other part. Here you do the tumorectomy, and within 1 week, and that's what is new here, in a short period of time, you will end up in a dramatic increase. I will show you example of the future remnant liver, which enable here to go to a stage 2. So what is new in this procedure is the speed of regeneration. You do not have to wait 6 weeks or 2 months, but this happens in a very short period of time. And I show you here just the first case we did in Zurich, a young patient with an atypical tumor, brain tumor, operated long time ago with liver mets. Not many things you can see in this X-ray that you would do otherwise. And here we have the possible future remnant liver here, and we did here the in situ split. You can see here that this liver, there is an in situ split here, and we look at the volume. We started at 19%, and within 7 days with an increase to 42%. And I must say that we were very impressed, and I could not really remember we had within the short period of time an increase by 90% of the future remnant liver. And in this young lady, we decided to proceed and to complete the hepatectomy, in this case successfully, with an increase again after 1 week after the second stage of another 64% in this first case, which means double basically the weight of this liver after we remove the diseased liver. Now here we came with a new operation, clearly difficult operation, and here I think anytime you come with some innovation, you have some people, and I think it's good, come with some criticism. So here is the first cases, what has been in the literature here. You have what available in the literature. You have a few papers. That's the first series of 25 cases. There has been a series from Brazil. I just go quickly here. Other series is published from Germany, another series here from Argentina, and in total, if we go here, we have 114 cases that have been reported in the literature of ALPPS, so not so many. All are retrospective, and they are usually from one center. There's a few multi-center, and the highest multi-center study that has been reported was from Brazil. Now, if we go here about the criticism, when I wrote that with Eduardo de Santibáñez, with very little experience in both centers, we just have the impression, and I think we're careful, that we had something new, that we have nothing, and we're so enthusiastic that we even write that may change the face of liver surgery. Well, this is a very provocative statement, and you can expect when you say something like that our friend and colleague come and don't believe this. And here this is a letter. There was many letters written to Annals of Surgery and others here by the group from MD Anderson, by Aloya and Vote, who wrote that here that we strongly caution HPB surgeon from experimenting with this technique. So basically, they did not believe, they were in the stage of belief in this operation here. And Jacques Belghiti, who had done a few cases with some issue, thought that we will not respect the no-touch technique. We've challenged that later on. And he likes this time between the two stages because he say we see the natural history of this disease and with the functional reserve, etc. And we have here from Japan also, and very well-known and established liver surgeon who were very worried about the morbidity and mortality, and they thought it's really too premature here to go really with this kind of procedure. So that's a typical situation where we have a few believers, few cases done, case reports, many case reports. Where do we go with this? So we have to compare. Now we have to compare with no randomized trial, and we have to see are we really doing something that has no place in liver surgery, or it is something we have to go further. And I will go relatively quickly for time to the few study here. You can see here that's a study that was done, not randomized study, retrospective, with difference in time and surgeon, many limitations in those studies. This is clear, small number. And here you can see, and that will be consistent, what they see is a difference in the time of resection. Again, 6 days here in this series versus what is known about a little bit more than 1 month if you do without the in situ split. Here from MD Anderson, they just took, in fact, the initial series from Germany, the first experience. They compare to the large experience with portal vein, and here they found no really difference, but again, a very important difference in the timing between both operations. And here this is a study that I would summarize in a few slides that we perform with a different group, the group from Pierre-Alain, from Santibáñez, us, and a group from London, Ontario, where we collected our cases of ALPPS, first ALPPS, so first time we did it, versus a portal vein embolization. And here we have again basically the same data. We could go for the second stage with the ALPPS in 1 week, while in the other situation it was between 1 and 2 months, consistent with what we have. I just summarize in a few slides this data that we have with 4 centers. You can see that the majority, so we have a lot of different diseases, the majority are colorectal tumor in this series. There was a good match between the two groups. I will not go here in detail, but you can see that most have diseased liver. They did a lot of chemotherapy typically from this patient, most than half had that, and some changes, many lesions, more than then, particularly in the ALPPS, have more than 5 lesions. So again, we speak very high population, and we were looking at the standard, at what we was from livers. You can see it about the same, or is the same between both groups. So we thought it was reasonable with all the limitation of such study to compare that. And here, for the first time, I think we were able to document that what we want to do, we operate this patient to remove the tumor. We know that the only chance for long-term cure, that's what we teach to all of residents, is to remove the tumors. So that's a reasonable endpoint in the short term, because we do not have long-term, and for the first time, we could show that in our hand, the standard 2-stage, we had a 66% R0 resection, while with the ALPPS, we have an 83%. And I would convince you that in fact is much higher, because many, as I showed before, patients in the first stage, the conversion, never reach stage 2. So we speak about the successful case at the end, so it's certainly not intent to cure. So if you look at the odds ratio, it was about 3.3 times more beneficial for the ALPPS procedure after adjustment. Now here is the concern that we had, is the mortality. The mortality, and I would remind for portal vein embolization and ligation, is not zero. It's not. It's maybe 5-6%. For the ALPPS procedure, it was, in the initial end, altogether 15%. Now, the one who did not reach the stage 2 in our hands was 25%, rather the lower one, but 25%, 1 in 4, will never go for stage 2, while in the ALPPS, we never observed that. We all the time in this series was able to complete stage 2, and the incomplete resection was basically the same between both groups. So again, if we look at the time of resection, this you can see the second stage of pure very, very early on for the ALPPS, that portal vein ligation, and if we calculate in an artificial way the regeneration in the ALPPS, that's individual patient on both sides that you compare. The speed of growth was about 35 cc per day in the ALPPS procedure, it was 3 in the other. So a dramatic difference in these two groups. Okay, so now we'll just go to other comparisons that were done here. We go back to the series here for MD Anderson. We were very critical initially in this. So what they took here, they compare here to the 25 groups that were published by Germany. They took all the patients here and they tried to match this in terms of the future remnant liver, etc. And they end up here to a number of 144 versus 25. So here clearly you have an initial experience by a German group who do that for the first time versus a center was major experience in portal vein embolization, including embolization of segment 4. I just want here in a few slides to summarize their data here with the morbidity, mortality, and just to come to the conclusion is that despite that, there was basically no difference between the small number, between morbidity or major mortality. There was a little bit more sepsis or need for laparotomy in the ALPPS procedures. But now we have to look carefully at this data. They start with 144, and let's assume they are the same population as the 25 German group. Now, 44 here, we can see that it was failure, no regeneration. We know that the portal vein embolization did not work, did some complication. They never go to the other stage. There was no surgery because comorbidity, failure of regeneration, and even those who were successful, there was a number here, 29, who would drop out because, again, insufficient regeneration, comorbidity, or very importantly here, you can see 24 had tumor progression. So tumor progression may not be a good thing during these 2 months. So we have a different number. We have a number here of, in fact, you offer that 244 patients, but only 100 patients will benefit from that. And if you look at the result for the series here, there's a dramatic difference between the 104 who really had the 2-stage procedure versus those who had no resection in this. So 30 patients never benefit from this surgery. So if we read the conclusion from this paper, that basically, based on this, based on its ability to select oncologically resectable patients and superior safety and efficacy, portal vein embolization remains the standard of care for patients with very low remnant liver. I'm not sure from this data that we can justify this conclusion. In addition, patients who will have tumor on both sides then are not candidates for portal vein embolization. Now, when we start this new procedure, we initiated here in Zurich and Buenos Aires and the group from Mainz, from ALPPS, we initiated a registry to try to learn more quickly the experience. And this is the data we had here by December 2013 with 248 patients from 56 centers around the world. And we did an analysis in those where we have more than 3 months follow-up to try to look at the major concern of this procedure, which is morbidity and mortality, and what patient maybe we should not do, or which patient we should do with these procedures. So just in a few slides, the summary of this data, you can see the majority of patients in the registry, in fact, had multiple possible colorectal liver metastasis, about 70% of the case. Again, here, many had steatosis or problems related to chemotherapy, and 70% of these patients had, in fact, heavy chemotherapy before. And here, if you see the standard volume before you do the procedure, here was 0.21, and it increased to 0.4, so a dramatic increase between the baseline and the time you go to remove the diseased liver, so just before stage 2. And the time for resection in the registry varied between 7 and 15 days, average 10 days, well below what is done normally for the conventional procedures. Here again, 98%, so basically every patient enjoy or had the chance to have the second stage and a benefit from this procedure. Mortality was 9% in the registry, and the serious complication, 40% complication that they have more than grade A. If we look at risk factor here, this is what we find usually in any kind of difficult liver surgery. Blood transfusion play a role. The duration of surgery, whether we translate more problems, but was important for the first stage. The age of the patient end up also to be important here, and patient who did not have colorectal liver metastasis had a different outcome. So if we plot here the type of tumor with the complication include mortality, we found that in fact colorectal liver metastasis did better than the other indication, and we can hear the cholangiocarcinoma. We also did in Zurich a few gallbladder cancer combined with Whipple. Those patients have not done as well, certainly, that the colorectal liver tumor. And if we combine here the better risk, so the relatively younger patient, plus colorectal liver metastasis, then we have a pretty impressive low rate of complication of 16% and a mortality 5%. It looks exactly what we have before for the conventional procedure, which was 6%. So for this group, we are in the same range. And here, if we take the group here of in-hospital mortality 4%, 5%, and complication 16% for these two groups. And here, if we combine all patients, the type of tumor, you can see a colorectal do better. And here there is really, I want to show that, a very significant good result if you take younger patients here and older patients that underwent the ALPPS procedure, and is the combination of age and colorectal liver metastasis, with a survival here at 2 years about 80 to 90% in this setting. Now, if we go back to some paper published in JCO, again by the group from MD Anderson here, and they published their data here about the two-stage procedures, but not the ALPPS, so the previous one, and you can see here for colorectal liver metastasis, now we can look a little bit better at outcome, because with one type of tumor, it's very difficult to compare different types of tumors. So here with the colorectal liver metastasis, and that's the outcome they have. So at 24 months here, they have about 80% survival here. And here, if we take colorectal and non-colorectal in our series, we can see that in fact the outcome seems to be the same. And here we have to compare a group who has large experience MD Anderson in this surgery versus a registry which is people who do that for the first time. So this is pretty encouraging that we have this result. And if we go back again, for those who did not, because that we had always to consider that, who had stage 1 but did not reach stage 2, that's the patient who reached stage 2, so they have this survival. The other one do not benefit at all from this surgery. They're probably penalized by having, in addition, possible complication from the surgery, while again in the ALPPS, basically everyone that's enrolled will benefit from the stage 2. Now, I just spent the last few minutes to speak about mechanisms. So here, from this data, we don't have definitive data, but we have certainly data that suggests that this procedure is indeed interesting, and indeed enabled to do things that we were not able to do before by accelerating liver regeneration. So here, what we wanted to do is to look at mechanisms. So we went back to the lab, and first to see whether we can have a model of ALPPS in the laboratory. So the mice liver is a bit different than the human, it's more lobulated. So you have to be a little bit innovative to have a model, but to make it short here, what we did here, we took a segment here, or a part of one of the median the lobe here, where we will do the split, and we will ligate the portal vein on all the rest. So we have a model of ALPPS in theory here. Here we have a normal blood supply, portal vein artery, and all the rest, the portal vein is gone. And to achieve that, we have to remove here a very small part of the liver. And then within 2 days, that's what it takes in the mice, regeneration is faster, we observe here an increased volume of this part of the liver who has still the portal vein and the hepatic artery. Here is the data in terms of graph. I go through that for you. Here we have the increased size that we have and the day after surgery, and you can see that's the control transection alone. This is the left lateral segment, the portal vein ligation alone here, or the ALPPS, and you can see it in this model that we indeed have increased regeneration. In fact, at day 1, we have a doubling of the volume of this liver, which indicate that we have a valid model here that mimic the clinical situation. Now, when we have that, we have to ask what are the underlying mechanisms. And here, that's the model in the mice, and you can see the transection that was done here with this small part of the liver here. That is the future remnant liver here. So we ask the question, if we do portal vein ligation, we don't do the transection, and we associate here injury to other organ to see whether it's just the discontinuity of the portal vein or is something else happening. And very interestingly here, that's the same graph that I showed before, we can see here that we do the portal vein ligation alone with an injury to the kidney or the spleen or the lungs with basically the same degree of regeneration, which is higher than portal vein ligation alone, so suggesting that injury to another organ induced the same degree of regeneration. And we did another experiment here to try to look further at that. We took the plasma of the mice who had the ALPPS procedure, and we inject that to animals who had only portal vein ligation. So what we were trying to test here is that we can transfer something in the plasma that will reproduce that, which is a really surgical experience here. And you can see here that the ALPPS and the portal vein alone without split, but the plasma will indeed regenerate more than any of the other group. And here suggests that we have, by do that, the release of growth factor, inflammatory factor, that are responsible for this procedure, for this regeneration. Now, in mice, we want to see what's going on in humans. So we had sample, we do routine sample in a few patients here. And this is in mice what we observe. In mice, we can see in the ALPPS with a dramatic increase of expression of IL-6 in the liver, which is more than any of the other technique. And if you look in plasma, also here in the ALPPS, there is an increase of the two main factors. There's certainly others that could be involved. So we went to our human setting here, and we compare here portal vein ligation with sample versus ALPPS, and we could observe here also a dramatic difference of this cytokine in human comparing one to the other one. This is only an observation. We have to be, of course, careful to say that's the reason for this, but that's an interesting observation here, and suggests again that the mice model is valid to study this further. So from this, we changed a little bit our technique for different reasons. In Zurich, we decided, in order maybe to decrease morbidity, to do partial ALPPS. That means rather than to do a total split as we do for living donation, we will do less than that, either half or 80% during the first procedures for to be more safe. And I show you here, as an example, one case that we did, a 60-year-old patient with colorectal liver met here, who present here 4 years after colon cancer with this kind of disease. This is a problem. And I can challenge here what we would do in this situation. Well, I think everybody will give chemo. And that's what was done, and here's already a good sign. The patient responds to chemotherapy. That's good, but that's not enough. There's still a lot of tumors. So we decided here to do a ALPPS only for segment 6 and 7. So the partition for segment 6 and 7 was our strategy. I show you the data here because initially, before we went to that, we went for the standard treatment. There was initially, we did portal vein embolization. And if we go to that, I will not go there. Here, we have 38% of this volume before, and it increased only to 42% after 6 weeks. So this is insufficient to go here, and there was no real increase. We did a biopsy which showed that, in fact, this liver was not very healthy. It was steatohepatitis with 40% macrosteatosis in this liver, so any surgeon would be very worried to go in this situation. And at that point, we decided to go for an ALPPS procedure of segment 6 and 7. That's what it looked during surgery here. That's the split here for segment 6 and 7. You can see this tumor after chemotherapy, the surgery here. This is an X-ray that we do at the end of, after 1 week after step 1, and you can see here the in situ split, and we did only a partial. We're worried by going here all to the right hepatic vein that will have more complications, and we decided, based also the knowledge in the lab, to stop here. And that's what we got here. If you want, we went for 42% to 49%. We wait another week. I think there's nothing wrong. And we got 55% 2 weeks after this. And at that time, we also did some tests. And you can see here the ICG green became much better, was 20%. We went to 4% here. And we decided to go for this surgery. And that's what we had here 1 week after a left tricectorectomy here. So a very dramatic increase from this segment 6 and 7. And this patient did very well post-operatively, and an increase here at the end to 65% 1 week after stage 2 in this situation. I just show you here as an example also a patient we did very recently. In fact, she just left the hospital. A young patient who came from another country, in fact, 37-year-old female with metastatic tumors. It's missing here because it was tumor in every segment in this lady. Here is the volume of the future remnant liver that we have here, which was 0.23, 0.5. She had massive chemotherapy and came with this typical skin problem from Erbitux that she had in this situation. So we decided here she also had a tumor in the left hepatic vein. So we did here, in addition, in this young lady, an RRE, a nanoknife ablation, during the first stage of the tumor that was lying on the left hepatic vein, and we did a partial split in this situation here. And 7 days after that, we have an increase by 71%, or basically a ratio went from 0.5 to 1%, which is a dramatic increase. The functional tests were also good. That's the view of this liver during surgery. And here, very impressively, after we remove here, so here's only the left part of the liver, the healthy part of the liver here, we have an increase by basically 200% within 1 week of this liver in this young patient who received so much chemotherapy. And that's what it looked like just during surgery, because in the other country they did also a very dramatic wedge resection, was some dilatation of the bile duct, so many challenging risk factors. And this patient, in fact, left the hospital about 9 days after the second stage of the procedure. So I finish here. Where we go? Well, I think this is obvious. We must go here to level 1 evidence. I think we have strong evidence that it is good, and we need a randomized control trial here, and we will do a randomized control trial, and we have decided to limit that here to colorectal liver metastasis for this randomized control trial. And we're very happy if people with experience in ALPPS want to join us. We would like to have the result as soon as possible. For all the other cases, I will really encourage everyone who do this case, particularly or also if there's any problem, to put in the registry. We want to know more about that. So conclusion, I think the ALPPS now, this is established, induce a degree of regeneration that we have not seen before. 2, it enables rapid removal of large and multiple tumors. Here, I believe this is a strong advantage when we know in series from major centers tumor progression is an issue. So we have more chance for complete resection. We still have today, and I think the message is clear, high morbidity, high mortality in this case. When we respect the criteria, probably less, but this is an operation still with an increased risk of problem. So the best cases is like the patient I just showed you before. There was 37 colorectal liver metastases. This is the ideal case for the ALPPS. And I mentioned the randomized control trial. We are working again on the mechanism which may help us maybe not to do the split and to have the same degree without split. I don't know whether it would be an advantage, but we are looking in this direction. I would even now caution the people, of course, that need to be done by center with experience in liver transplantation. Those even with some experience in split transplantation or living donor is an advantage, and it has to be the right indication. If you go in the registry, major surgery beside that is associated with. Now, what you should not miss, because it's just here an introduction, is what will happen tomorrow. There will be a debate here. The chair of this will be Mr. Vote. I'm not sure if he's in the room, he's totally unbiased, but he will be the judge of that. The defender of that is my colleague and friend Eduardo Santibáñez, who will present the ALPPS, and the one who will at least try to speak against, I know he's no longer against the ALPPS, is Dr. Professor René Adam from Paris. So I really encourage to come tomorrow and to listen to this debate, so we have here both sides of the discussion. And I thank you so much for your attention. Thank you.